you asked me to resume the goal of my speech in 3 points. So the goal of my speech is that at the end you know how to diagnose and recognize actinic retinopathy, what are the most important complications and treatments, and what about prevention. Let's start with a case. This was a patient I saw for the last time last Monday. It is a 62-year-old male patient, as you all can see, with a parapapillary melanoma, had lots of hemorrhages, cotton wool spots. So I explored a bit further with panoramic angiography, where you all will be horrified to see that there is no vital retina left, a little bit here. And the question is this radiation-induced retinopathy? Okay? Does anybody have any suggestions what you would like to do next to answer this ischemia? Is it radiation-induced? Yes or no? What I did was, he is a diabetic. If you inject fluorescein, you might as well check the other eye. And you see that there is an asymmetry. So it's not, at least this ischemia cannot be, or clinically at least, is not symmetric to the diabetic retinopathy there is in the other eye. So that's an argument in favor of radiation retinopathy, isn't it? Might also be infiltration of the disc. Now, nobody reacts. I lied to you. Or I kept part of the information of you. Because this patient I saw not only for the last, but also for the first time last Monday. He has not been irradiated yet. So, by definition, this can't be radiation retinopathy. So, what is my message here? And this is something that has happened so often, is that you get a horrible retinopathy. Patient somewhere in the history suggests that there has been irradiation, and they ask you, how do you treat it? And you say, stop, 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 guys. That's the first thing you need to do. That is to, as there is no specific clinical fundus to differentiate from other inflammatory or vascular retinopathies, the first and foremost thing you have to do is give me the treatment plan. And then, has there been irradiation in the zone? And then we start business. So that's the first and foremost. You might be surprised how many we jump to conclusions. So no, has there been irradiation in that zone? First and foremost. You agree with me, yeah?
Thank you.
So let's exercise, let's practice a little bit. This is a patient, parapapillary choroidal melanoma, has had proton therapy, and you see that here at the distance there is choroidal ischemia. Is this ischemia radiation induced? So now you all say, all together, show me the treatment plan. And then you see that, as a matter of fact, this is a proton therapy plan. So with the fundus view, you see the scheme of the tumor, the clips, and then the 90, 50, and 20%. And you see that, as a matter of fact, the beam was such that it has approached at the distal, the peripheral superior, nasal superior choroid. And so this is compatible with radiation-induced choroidal ischemia. The plan is actually copy-paste nearly of the ischemia you see projected on the fundus. So this is compatible. Okay, let's go towards another one. This is a melanoma that has been treated with proton therapy. And 1.5, 2 years later, this is the panoramic angiography. And you do see, okay, this perilesional ischemia, you might expect that this is the safety margin of the radiation, that it probably is radiation induced. But this one is like the previous case at the distant. We look now at the beam. It's an old plan. And you see here, so this is the collimator view of the protons. And this is, so the hole in the collimator that has collimated the protons going like this to the patient, all this part has not been irradiated. And if you go then through the tunnel and you have the axial view, then you see that the beam has stopped. That's the beauty of the proton beam. It doesn't go like photons very slowly, but it stops at 1.5 millimeters behind the tumor. And my clip is indicating to the radiation oncologist until where they need to include where the posterior border is of the target volume. And you see very nicely this is the optic nerve, and so there is a distance. The optic nerve has not been included, which means that this retina that probably is somewhere here has not been irradiated. So this is not radiation-induced ischemia. This is. Why is there ischemia there? Because it also, the optic nerve has been spared. Otherwise, this vessel might have been hit by the beam, and you have then, obviously, from the moment the optic nerve is hit, you can have also, the whole retina is at risk of developing a radiation-induced ischemia. This is actually what we discovered thanks to the panoramic angiography. Before, when we had the small, just the small views, we went looking there where we had irradiated, but we didn't scan the whole of the retina. And while doing panoramic, we all of a sudden discovered that at the distance from where we irradiated, there was also ischemia. And in the beginning, we didn't understand until we understood that when you do ischemia, as with the first case, when you do panoramic angiography at the first case, there is already ischemia present induced by the chronic retinal detachment. So no, the inferior part is not radiation retinopathy. Okay, so look at the plan also for the cataract surgeons. When you operate on patients that have been treated with proton therapy and the oncologist says, okay, go for it, you can go for the cataract, look at the plan, because there you will see where the protons have gone through, and there you will have scarring problems, and where you can go without a problem into the eye, and where you won't have scarring problems. So look at the plan. Type of irradiations. I talked already about protons, you talked about photons, and then we have the brachytherapy, which we use in radiation in, we have the plaques, the ruthenium plaques versus the iodine plaques. And why is it important to be aware of the differences? Ruthenium plaques give beta irradiation. And beta irradiation is very elegant in ocular oncology because it is very intense at a very short distance, and then it drops very quickly. So for small tumors, you can very well burn at the base, and the other side of the eye doesn't get touched. So the retina is safe, the other part of the retina is safe with these plaques. So that's good for small anterior accessible tumors. On the other, and there you don't need to worry about radiation retinopathy at a distance. On the other hand, with iodine plaques, that's gamma irradiation, and you see here how far the radiation travels towards the other part of the eye. And this is the very reason that all the centers that have access to proton therapy don't use iodine plaques, or nearly not, because of the radiation retinopathy. Okay, other radiation parameters, the dosage. Our colleague has already discussed about that, dosage, fractions, and obviously that depends, as the dermatologist says, to the diagnosis first and foremost. So already the diagnosis will give you an idea, okay, this is a low or a high irradiation, probably even if you don't have the radiation plan. And so standard for your information, when we irradiate circumscribed choroidal hemangioma with protons, we went for 20 and now we go for even 18 grays because we have seen radiation retinopathy with 20 grays. Okay, it's hyperfractionated, but it's still 20 grays is really Under 20 grays, I've never seen radiation retinopathy. Above 20 grays, I have seen it sometimes, even in these young patients at 10, 15 years. Metastasis, classic metastasis, I'm talking about lung adenocarcinoma or breast. It's 30 grayish, and then the fractionation, the less you fractionate, the more aggressive the radiation insult is. So you will, well, the radiation oncologist knows it, but the longer the life expectancy, the more you will try to fractionate because hoping that you will postpone the radiation retinopathy. And then they have the melanoma. You first have to cure the patient. So there, without under 60 grays, you will not kill the melanoma. The melanoma is radiation resistant. And then we have to deal with the side effects afterwards. There is another thing. Timeline since treatments. If you have apart from the ischemia that was there as present, and you have to document at presentation to know where you stand, but if there is no ischemia whatsoever, it's very unusual to see a radiation-induced retinopathy in choroidal melanoma before 1 year after treatment. So if you see a retinopathy during the first year that is new, be aware and think, might this be a branch vein occlusion? Might it be something else? Timeline since irradiation counts. And classically, I would say between 13, 14 months, 1.5 years, I see them standard all at 1.5 years post-proton therapy, because, and then I go actively looking with my panoramic angiography for the ischemia, as you see here, and then we treat it with laser to get the patient cured. But in this case, what you see, there is a radiation-induced optic neuropathy, and the optic disc in this case probably has had the full dose at the site of the melanoma and a partial dose at the other site. And so that means that 6 months later, when we had treated this part, ischemic part, with PRP, and you see aggressive PRP, then all of a sudden this part of the disc says, I've been irradiated as well, and then this vessel got blocked. So you can have sequential ischemia from the moment the disc has been irradiated. So you cannot say here, okay, I've done my job, I've done, bye-bye, see you in 1 year or 2 years. There is this critical timeline between 1 year, 3, 4 years, where you can have sequential ischemia. I had a youngster, and the young patients obviously have excellent cardiovascular health, who only developed his radiation retinopathy 15 years after his proton therapy. And obviously he was not so intensively followed, and so he finished with neovascularization because nobody bothered really to go actively hunting for it. Okay, let's continue. So consecutive ischemia, be aware of it. On the other hand, if you have the plan and it's a peripheral melanoma and you really have covered all the ischemic part, then you're more relaxed. Then there are the patient factors. So all the cardiovascular risk factors, smoking, obesity, diabetes, whatever damages the vascular endothelial, makes the vessels more at risk of the micro-occlusions. Also patients that are under chemotherapy, be aware of that. And then there are the tumor factors. There is the tumor height, the higher the bigger risk. There is the parapapillary location, and then there is the retinal detachments. Those eyes are at a higher risk of developing actinic retinopathy and neovascular glaucoma. And by the way, those are also the indications where we can't do brachytherapy and only can do proton therapy, which at the beginning, so Mr. Hungerford has given a very bad reputation to proton therapy in the 90s. They say it's not worth it. If you have to do proton therapy, you might as well take out the eye, because they all end up in neovascular glaucoma anyway. And there is some truth in it. So that was about how to diagnose, get a feel of, is this radiation retinopathy, will it become sooner, later, and there's the absolute thing, the tissue has to have irradiated, or its vascular supply at least, and all the other factors are relative. But you have to have a feeling how quickly can that come. Second chapter, complications and treatment. The thing to be always aware of is neovascular glaucoma that can still lead to the loss of the eye, though it has become rare. And there I need all your help. Whenever you refer a patient to me, I cannot let them come to Lausanne all the time. And so please, if you see them in intermediate controls, go and hunt for rubiosis. When I was in training, we rented for rubiosis with diabetic retinopathy. As a resident, we always had to look. But now, because there are the anti-VEGFs, I don't know about your residents, but mine, they're very light and they are not so stressed about hunting for the rubiosis, and they don't recognize it anymore so much. So I'm a little bit worried there. I mean, correct me if I'm wrong. So how to treat? Sometimes I have a patient at my consultation, all of a sudden there is a rubiosis. What do you do if you have a patient, you have rubiosis, early glaucoma, perhaps one eye is 12, the other eye is 20 millimeters of mercury? What do? Do you say, okay, I'll give you an appointment next week, now I'm busy? What I'm concerned, from the moment I see rubiosis, that's an emergency. I have, like the gynecologist, access to the injection room, and I can always add a patient to do straight away Avastin. I don't ask any permission, or whatever you have. If you have Eylea, Lucentis, Echantillon, I don't know how to muster, how do you say it? Go for you, and whatever the Krankenkasse, it's better to ask for forgiveness than for permission when you are treating neovascular glaucoma, even at a very early stage. You inject first and you justify yourself afterwards, because you're saving the eye basically. So, and if you have 40 millimeters of mercury, then you put them first on the Diamox, whatever, you drop all the drops, you can have to have space 20 millimeters of mercury to then inject the same day. And then you also put them on the anti-glaucoma, the steroid drops, atropine, until you see them 4 weeks later. In between, you ask the general ophthalmologist to have a look at the pressure, and then usually the eye is quiet. All the early rubiosis, fresh, has disappeared, and then you do, this was an eye that had already, PRP is complete. The fact that there is neovascular glaucoma means by definition not. So you repeat the angiography once the eye is quiet, and then you see there are still some holes. And sometimes I'm surprised how much a complete PRP can still be not complete. And you just go again and you grill the eye. How to treat late neovascular glaucoma. There we have a study. The only thing to really save the eye, after that you again make it quiet and whatever, but to treat the pressure then is Barfeld shunt surgery, or Ahmed, whatever your surgeon, glaucoma surgeon, is most comfortable with. There is one big condition, obviously, if you're treating melanoma patients, that is, you have to be absolutely sure that your melanoma is under control, that there are no cells from inside, from outside. We had lots of difficulties to get this patient, this paper accepted in the BJO. But we now do total anterior segment irradiation for these anterior segment melanomas, and then by definition, I mean, we don't have any tumor recurrences once you grill the whole anterior eye. You have then cataract, you have a dry eye syndrome, which you prevent with grafts. That's another story. But at least if you do then Barfeld surgery, you can have beautiful results. This is the glaucoma results, so 29 millimeters of mercury on 2.9 medications. They phrase it, and they'll post-op IIP 14 millimeters of mercury on less than 1 medication. On 25 patients, we lost finally only 3 eyes, one from iris necrosis and 2 from perforation. Okay. First complication, loss of the eye due to neovascular glaucoma, early and late treatment. Second complication, loss of vision. There are different reasons why the vision is at risk. There is radiation optic neuropathy that we then obviously again do a panoramic angiography. The choroidal ischemia is quite fine, and here you see there is mostly sector nasal ischemia with still quite good posterior vascularization. And before that we just gave up. And what we now have thought that you have different kinds of optic neuropathy. When a big vessel has been closed, forget about it. But if it's only a microangiopathy, we discovered that intravitreal anti-VEGFs, again in an emergency once every 2 months for at least 6 months, you can recover visions. And I am talking about counting fingers to 4/10. And you never know whether it will work or not, but it's always worth it. I mean, 4 out of 10 is still legal vision. I mean, you just inject and you see whatever happens, and you do it once every 2 months for 6 months. It has been published. And then, again, you hunt for all the zones to be lasered, and you might continue then, but we have recovered these optic neuropathies. And then there is a loss of vision because of inflammatory macular edema, typical in the anterior segment melanoma. So you are kilometers from the macula, who definitely has not been irradiated, and still they do edema. And that's the same principle as with cyclitic uveitis. So there, it's not the vascularization that's a problem, it's the inflammation that's a problem. So what do? Steroids. At least you try. It might not work, but I have some patients who are now for years on Ozurdex once every 4 months, and they keep vision. So, and then you might give it a try first with subtenons. Obviously you have the steroid responders, obviously you have the cataract, but again, we have good cataract surgeons. And then there is the death, ischemic actinic maculopathy. Here, a patient that was referred to had had ruthenium plaque therapy for a posterior melanoma, which you normally don't do elsewhere. And obviously, as I told you, type of irradiation is important because there the base is more burnt than the top. The choroid has no chance, everything is burnt. And with such an ischemia, vision, hand movements, counting fingers, no therapy can be done. By the way, in case you are considering a patient, an elderly patient, long way to travel to Lausanne, limited means, but it's an only eye, what do you do? Or it's the best eye. Just for your information, we did a study where we took the opposite approach. We said, which are the posterior choroidal melanoma patients that still have good vision after 5 years? And we were surprised to see that small posterior choroidal melanomas, 20% have a chance of having more than 6/10 of vision after 5 years. We were surprised ourselves. We just had some cases and we said, let's have a look. And so we did that an approach. We could put all our posterior choroidal melanomas into a study. And then we separated the ones that had good visions versus the one that had less good vision. And we said, what's the difference between them? And what we discovered is that the parapapillary nasal ones had better chances of keeping long-term vision before the anti-VEGF era than the parafoveal ones. So the fovea is more radiation sensitive than the optic disc. So parapapillary nasal choroidal melanomas can end up with good vision and before anti-VEGFs. Let's go to the last chapter, prevention. How to prevent neovascular glaucoma? Because, I mean, once there is chronic neovascular glaucoma, even if the new vessels have gone, the old mature vessels are still at the angle with fibrosis. It's a bother. Well, there is a study of Dr. Mantel, my colleague of medical retina, who actually did a case control series some 10 years ago, where in some patients we injected bevacizumab, and that was the ones that had already ischemic retinopathy at presentation, and compared that with a group that had not had bevacizumab from in the beginning. I'll give you the protocol later. So the two groups were perfectly to be compared, and we were surprised to what extent anti-VEGFs were efficacious. You see here that the ones that had not prophylactic anti-VEGFs developed rubeosis in 40%, confirming the negative prejudice towards proton therapy, while the ones that had once every 2 months for 6 months after proton therapy and once every 3 months after, there was just 1 or 2 patients that did not continue the protocol who ended up with rubeosis. All the others not. So bevacizumab significantly reduces the rate of iris rubeosis. So practically, how does this protocol work that now I'm applying systematically in my practice? At presentation, when I have a melanoma, you see the melanoma, you see the retinal detachment. We do panoramic angiography. In this case, there is inferior ischemia already at presentation, so not radiation induced. Then those patients, we already start anti-VEGFs at the time of tantalum clip insertion. At the end of the surgery, I do another drop of isobetadine, and then I do the injection, not in the tumor, not always temporal inferiorly, usually superiorly, because inferiorly there's a detachment. I repeat it every 2 months thereafter for 6 months, then every 3 months, until the retina is reattached. That might take 1, 2, 3 years. When the retina is reattached, I repeat the panoramic angiography, and you will see systematically that the ischemia has become more extent. So I know then what the extent is of the retinal ischemia, and then on the basis of that, I will do my PRP, which allows me for that indication to stop the injections. However, if at presentation there is no ischemic retinal detachment, I don't start bevacizumab, but I will repeat it at 1.5 years after radiation to then go hunt for radiation-induced retinopathy to treat it with laser. However, if the disc has been irradiation, I do the same. Here there is also some cataract, as you see. I treat the ischemic areas with laser, but then I will continue to observe to make sure that there is no sequential retinal ischemia, and then to continue to laser to avoid neovascular glaucoma. This is really, I mean, if you decide to do proton therapy, okay, the tumor, the source of metastasis has eliminated, but there is no use to do proton therapy and then stop following the patients. That means if you do proton therapy, the work is only started, and then you will be busy for some years to prevent neovascular glaucoma. And then it has been worth. And then last but not least, how to prevent ischemic maculopathy. We have now published recently 2 papers, 2019 and 21, where we found out that the parameter that is most eloquent to announce the beginning of radiation maculopathy is angio-OCT, the foveal avascular zone, because if you treat patients not with anti-VEGFs, at a certain moment, more than 1 year after the proton therapy, the fovea avascular zone will start to enlarge. Even if you start but you give up afterwards, you will see progressive ischemia. However, if you have, for example, this 47-year-old lady at presentation where we started our prophylactic protocol for neovascular glaucoma, the mantle protocol, and then when the retina was reattached 9 months post-protons, we did the panoramic angiography, treated her with protons, and the question was, do we continue? And then, with the prophylactic anti-VEGF, I just told you now, you're allowed to stop, but we then checked, according to the recent study, the foveal vascular zone. Even if the vision was 100%, the zone started a little bit to enlarge. So we said, why not continue? And the protocol that was established in Lausanne, there are different protocols over the world, but the Lausanne protocol, it's between 2 or 4 months injections. Once every 2 months for the first year, once every 3 months for the second year, and once every 4 months for the third year, so an anti-VEGF. And see here how nicely the foveal avascular zone is preserved with a vision of 0.3. The PAP disc has been irradiated, and this 3 years post-protons, and not for a small melanoma, for a big melanoma. And this is another example that was published in the study 36 months after the start of the protocol. So the protocol was above. See how nicely you can buy time. I'm not saying that in 10 years you still will see, but so far so good for certain patients. And you see here, so the evolution of visual acuity, the ones that got protected, that got various protocols, and that one that were not protected. So it's not a PRN protocol, and I have to fight sometimes with certain local ophthalmologists say, but there is no liquid, why would I inject? And why do you once every 3 months and not why every month? And they get completely confused with the medical retina protocols. I say, no, this is the reference. You are just, because of the antimitotic effect, you protect actually, you prevent the division at the endothelial, and that's how actually you postpone the occlusions at the level of the micro circulation. So in conclusion, diagnosis of actinic retinopathy, absolute factor, has the retina or his vascular supply been irradiated? Relative factors, all the rest. The type of irradiation, the patient, the tumor-related factors. Complications are both eye and sight-threatening. Treatment of neovascular glaucoma is urgent and complex. Optic neuropathy and inflammatory macular edema can be partially treated, and it's best to go for prevention when I'm talking of both neovascular glaucoma and ischemic maculopathy, because now we have efficient prophylactic anti-VEGF protocols. I thank you for your attention.